Before we get started, I'm going to do a little brief bio to introduce you.
Okay.
Dr. Garfinkel is a Valley Medical Group obstetrician and gynecologist with more than 30 years of experience in the field. He is also a Menopause Society certified practitioner. Hey. He sees patients through Valley's Menopause Center, a place where menopausal women can seek care for their symptoms from certified menopause practitioners. And that right there, I think, is such a huge part of what myself and my co-founders, Allison Kalshed and Stacy Torriello, have been really trying to do, which is help bridge the gap by bringing our women in our community information that we find because there is such a lack of menopause certified practitioners. So on behalf of every woman, thank you.
Very kind.
Because I know that that's extra work and extra time. So, what prompted you to seek out this additional medical education, menopause education?
Well, first of all, thank you for the things that the three of you guys are doing. It's awesome to help with the community. So my hat's off for what you're trying to accomplish or are accomplishing, from what I understand. I've been an OB/GYN for 30 years. And when you asked me to give this talk, I was thinking back about the beginning of my practice. And I remember years and years ago, I would give little talks about menopause back like 30 years ago. So I've been dealing with this topic personally as an OB/GYN for a long, long time. And so I recently had a switch in my job status, leaving a practice for many years. And I had some time off before I recently joined Valley about a year ago. And during that time period, I did some really fun stuff, but also took the opportunity to become a certified menopause specialist. And I did it because I just wanted to prove that everything I've been doing is up to date and making sure that I'm doing right by
Mm,
patients.
hmm.
So it just gives me the credit, to feel comfortable that I know what I'm doing in terms of it really didn't change much what I was doing, but it was more just to certify that I was doing right and keeping up to date. As a physician, it's so important
Hmm.
to not just do what we've been doing 30 years ago, but be up to date on the latest evidence. And so much has been changing. And as you know, menopause is definitely having its moment. And so I'm really proud and
Yes.
excited to be part of this process.
Well, it really is a moment, and what I've been hearing more and more, and I totally agree with, it's a movement now, really. There's a whole generation of women who aren't willing to just accept the no, it's all natural part of the aging process and leave it at that. And just, some of the other things that have really been upsetting to hear providers telling women about how to help with the symptoms or things that they're feeling. And so it's really appreciated that you did want to keep current because even in the last year, it's just like been a snowball of great things, not bad things, but great things. The FDA and the removal of the black box warning was so tremendous and such a big shift for the work everyone's been doing in that space. So I'm sure too, as you've been seeing patients over the years, or I can imagine, I'm not going to say I'm sure, but I can imagine that you've been getting those questions and being able to answer them and understand what kind of treatments there are available. I'm sure have people been just talking about it more, even before maybe you started with the menopause center?
As someone who's been doing this a while, I I don't know if you know much about the history of hormones. I've been doing this back when, I don't know if you back in the day, women started taking estrogen as the fountain of youth. There was back
Mm,
in the 70s, there was Feminine Forever, and people were searching for how to live better lives and longer. And I've been around long enough with that pendulum that was swinging. When I first started, I was prescribing estrogen hormones and saying to persons, you should be on it for the rest of your life. And then obviously the pendulum swung back way too off to the other side. But I never stopped being an advocate for HRT. It makes total sense. It never made sense for me to stop it the way the Women's Health Initiative or was responded to, or how people took that whole process. So to me, it really
wow.
hasn't changed much for me and my patients. But um, but obviously now it's just that much better, as you mentioned, the FDA going above and beyond, not just for local estrogen, but for systemic estrogen, which
Mm-hmm.
the tragedy of so many women not being able to get treated over the last 10, 15 years because doctors feeling uncomfortable with that FDA background. But for me as an OB/GYN, we prescribe medicine all the time that are, off label or for other indications. So to me, it never made sense to stop prescribing estrogen.
That's great because I have just heard a majority just like absolutely not going to prescribe it. And that health initiative study, which, as we know, was reported incorrectly and didn't provide all of the context behind the findings. I'm really impressed that you continued because you felt confident in what you were doing and the treatment you were providing because you understood and knew the benefits, and that's commendable. Um,
It's just this basic science that women benefit from estrogen over their life in so many different ways from head to toe. I can go on and on about the many benefits, but obviously for vasomotor symptoms and osteoporosis is a discussion that's so under talked about. But I can
yes,
speak personally. My mother, who's 91, God bless her, she literally fell downstairs and she never thanked me how much I kept her on Prolia, a medicine to prevent bone
right.
loss. So it's so many women suffer in silence from osteoporosis. And I can go back. So years ago, I would prescribe hormones for reduction of heart disease and vasomotor symptoms, osteoporosis. But now we have other drugs like Lipitor and cholesterol medicines and medicines for osteoporosis that we never had when we first started producing, just using estrogen only. But it's still such a strong benefit in so many different ways that I think every individual needs to have that discussion with their provider to go over their own individual risks, their own individual results and labs.
Mm-hmm.
And that's such an individualized process that it's not, the same medicine for all kind of thing. So that's what I
Sure.
try to do. I literally sit down and go over the pros and cons, take the history, and have that discussion.
And
So
that's so important. That is a very key piece to this is like it is truly a discussion with your doctor and understanding if there are any risks or just understanding what the process is and what the benefits are. Um, I'm also curious. We got a question from the chat, which is very active right now. During this period of time after the Women's Health Initiative study came out, did you have other colleagues um, in the same practice or the part of medicine, OBGYN? Sorry, I'm having a brain fog moment right now. Uh,
we could talk offline if you like.
other gynecologists who might have had a different opinion or defied your decision to continue to prescribe estrogen. Did you find that during that period of time to be the case at all with anybody?
I mean, there's definitely, even today, even when patients see other specialists like an internal medicine doctor, they'll definitely say things that are contraindicating of things that I might have said in terms of benefit,
Mm-hmm.
heart disease, and other things. So that's sometimes a very big frustration because I know some of the benefits. People are very scared about taking hormones. I mean, there are obviously some risks, but in general, the most times the benefits far outweigh those risks. So patients
Absolutely.
need to know. I need to. My job is to empower women to make them understand why they're taking it and understand what those benefits are compared to the risks so that they feel good about taking that medicine every day.
Sure. And just to take one step back, when you mention the word risk, because that's the first thing, like everyone, their ears perk up, the risks being more related to the individual's medical history, if there are any comorbidities and that sort of thing. Are those the types of risks you're talking about?
Sure, obviously family history comes in play in terms of risk of cancer and other medical issues like blood clots, and having strokes. But obviously their own individual risks based on their cardiac risks. I can go on and on about the different medical issues, diabetes, rheumatological issues,
Mm-hmm. Mm-hmm.
medical issues. So that's a conversation that needs to occur.
Sure.
And I feel very blessed that one of the things that happened when I started becoming the menopause certified, I went to the Menopause Society meeting in Chicago, and it was prior to me joining Valley, and I met these two other doctors who I'm not sure if they're on the call, but both Kathy Kim and Michelle Beloff are, along with Tia, who's our chairperson. The two other people were there from Valley. The three of us got along, and we spend time together. And that's one of the ways we started forming this menopause group here at Valley. So
Mm,
so I thank Tia, who's our chairperson, for allowing us to have this center that we can spend a little bit more time and not rush people in a 15-minute kind of
yes,
visit, to really spend the time to educate and hear and listen and hear what where people are at. So,
absolutely. And
so
can you give a little bit of more information about the menopause center that Valley opened, how long it's been open, and the kind of care that you provide?
it's an idea that has been percolating for some time. I mean, I don't, I think it's since last summer where the idea was percolating for a couple months, but maybe last summer is when we really opened it. It's a group, there's four of us as OBGYNs, but we've been very lucky to have several other specialists that are within the Valley system as a multidisciplinary team. And that's one of the benefits of being in a group of multiple specialists who have
Sure.
interest in women's health. So we've reached out and have a group of people that we feel very comfortable referring to. And through our electronic records, it's easy for us to refer to those different people for sleep apnea, for cardiac, cancer, oncology, et cetera, et cetera. So we formed this little group of people who feel very comfortable and passionate about women's health and this part of women's lives.
That's awesome. I know I've found personally as I've gotten older and really embarked on this journey, if you will, of perimenopause and menopause, you really have to develop a team of doctors and providers because while most of your symptoms are due in part to the fluctuations in estrogen and progesterone and testosterone, it also does require you to see more doctors, endocrinologists, if you have osteoporosis or osteopenia, like I do, cardiologists to make sure that your heart's in good condition. And the list gets longer and longer. So I think that's really a great benefit to have the connection with those other providers who are in lockstep with you about the care you're providing and coming at these patients understanding that the systemic changes in estrogen are impacting all of these different systems in your body. So that's amazing that you've
Yeah,
got
you
this whole
actually,
group.
you were one of your team, titled the lecture about changing landscape of women's health. And as you know, a lot of doctors are not in their little offices in small private practices anymore. Most of us are now part of these big systems, which is good and bad. But one of the good things is that we're able to work under one electronic medical record. So we see what everyone else is doing. It's so easy nowadays to be able to see when you see that endocrinologist or cardiologist, we are seeing those records and communicating very easily. So that really
Mm-hmm.
us to have that under one group, I would say.
Yes, absolutely. It definitely cuts down on the amount a patient has to explain and the history, and it's a good shorthand too, which is great.
Yeah.
Um, so with the rise in these centers and the brick and mortars and the telehealth that are coming up that are focused exclusively on women's health, like can you talk a little bit more about that? And I guess it comes back to what you're saying about menopause being a movement. Do you feel like the future is going to be more of these specialized systems and that are, oops, that are focused on women's health, especially at this stage of life?
Yeah, I mean, I think it's clearly having its moment. Oprah had a big show that you probably saw that was pretty awesome. It's a matter of access. That's a major issue in healthcare today about having that access to great providers. And that's where telemedicine, all these companies that are popping up. I have a sister that might be on this call who she's a nutritionist and works for a company that offers menopause help. So, yeah, I think patients are demanding that access and availability with providers. And that's, if you look at the Menopause Society numbers, it's like exponentially increasing people, doctors, providers who are willing to be more of an expert in the subject. It's the amount of people becoming certified members are increasing exponentially. So the answer is yes. It's not going away.
So encouraging. It really is. I have to share that there is a friend of mine who um, is really struggling right now, and she is getting what I would call misinformation from the provider that she's been seeing for a while now, and is really trying to figure out like what her next move is. And I really am encouraged by the fact that there is now a combination of brick and mortar, whether it's private practice or these menopause centers that are starting to become more well known or popping up. Um, the telehealth in particular, though, especially if you live in an area where you don't have access to certified menopause specialists, I think is a really good opportunity for women like herself to
Absolutely.
have that option.
Yeah. Agreed.
Does does anybody do you in the menopause center, do you have a telehealth option or is it
Yeah.
all you
Yeah.
do?
Yeah. I do telemedicine a couple times a day.
That's great. And is it with people in New Jersey or is it out of state as well?
No, I think, don't get me. I'm not sure. Mostly it's for New Jersey, but we definitely have
Okay.
patients that live in New York. I don't want to get in trouble about the legality of telemedicine and what
And I'm sorry
our law
that that
says,
doesn't.
but I believe the majority. I'm I'm licensed in New Jersey, so I'm a New
Okay,
Jersey license. So
got it.
I'm not out. I can prescribe in other states, but I'm not licensed to give care potentially. I think, but I'm not. It's beyond my expertise, so I let Valley help me decide. But most of my patients I'm doing
Sure.
telemedicine are local, so
That's great. And it's good that that's still an option too.
yeah.
Um, so one of the topics of particular hormone therapy is testosterone. And I know that that one is a lot more sensitive of a topic because it's not FDA approved for women, but I understand that there are opportunities to be prescribed it if you are identified as hyposexual desire disorder. I don't know if I'm saying that correctly and if that's
Hyperactive.
accurate.
Yes, yes,
Yeah.
hyperactive sexual.
So what are your thoughts on testosterone? Is it something you feel is a good part of the regimen or makes sense for women um, in that particular case that you're allowed to prescribe it based on symptoms?
So just to give a little background, back in the probably around the early 2000s, Procter and Gamble tried to get FDA approval of testosterone, and it was not approved back then. The rigors of it being approved were definitely higher bar than testosterone for men, of course, but
Of course.
I think it was unanimously not approved, and so P&G, with all their money and might, backed away and stopped promoting, moving forward with that. I think another company, maybe in 2011 or so, something called Libigel, that tried again. So at this moment, any testosterone that we prescribe is off-label and not approved by the FDA. There's a lot of great content out there about does testosterone work. It's not so simple. If you give men Viagra or a pill that is out there for erectile disorder, 98% of men will be aroused, etc. But there's no such simple pill as that for women. Uh,
Hmm.
Although there are two FDA approved medicines that are approved for hypoactive sex drive. I don't know if I'm allowed to talk about the names of the medicine. I'm not trying to promote any medicine. And by the way, I'm not offering any medical advice to anybody at this point. I'm
No,
just,
no, this
yeah,
none of this,
so I'm
and we
just,
can say this right now. None of what we're
yeah.
discussing is for medical advice. It's more just your point of view on the
Right.
healthcare in the state.
So I don't know their exact genetic names, but there's two medicines named Addy, which is a pill. It's called the pink pill, and Vyaleesi, which is an injection. Those are FDA approved. And in fact, you brought up news about the FDA with estrogen. Recently, the FDA approved Addy for not just premenopausal women, but for postmenopausal women. So those are two things that I prescribe that are in our armamentarium.
Hmm.
Testosterone I prescribed for years. I wouldn't say there's a lot of placebo effect, so it's really hard to discern. But
Mm.
definitely patients that I have feel much better on testosterone. In fact, I can give you a little annotation. Years ago, I was doing an oncology fellowship for a year, and the doctor that I was one of my mentors. She actually became the president of the Society of Gynecologic Oncology, and she was president of the American Cancer Society. She was an amazing physician. She would give testosterone to all her oncology patients. So I would give an injection, pretty high dose, once a month to oncology patients to help them have more oomph, to have more energy, because
Right.
cancer can cause chronic fatigue. So I was giving testosterone back in my training days to women, but not for sex drive. But
Hmm.
definitely over the years have seen people respond. They definitely feel better. Um, but there's definitely patients who don't respond. We start at a low dose, and for many years we didn't check blood levels, but there's now a movement to start checking levels, especially as you're dosing and prescribing, to make sure you're not prescribing too much testosterone, because
Hmm.
there is a potential negative downside to too much testosterone excess. Um, but there's definitely a lot of benefits besides testosterone. And so muscle mass topic is becoming a huge issue in our world
Yes.
with GLP-1s and people losing not just fat, but muscle mass. Uh,
Hmm.
Testosterone may be a helpful part of that. So I think eventually it'll get FDA approved. It may not happen in the next 5 years, but I do see it happening. Um, so there's exciting stuff on the horizon.
Yeah. Yes, for sure. I have to say again, a personal opinion or focus group of one. I have found that I have really seen a turn and shift in my energy levels for sure, as well as definitely the intimacy, but also a growing sense of like confidence that I had lost for so long. And maybe that isn't testosterone, but I tend to believe that the combination of what I'm taking right now, that was the last thing that I took. You know, it was the last thing on the list of seeing how things work, and that was the last to be added in. And I've just felt, I don't know, confidence is definitely something that was lacking, and I truly feel like that might have had something to do with it, but
Yeah,
I
that's
feel so much better.
that's awesome. I definitely have patients who, in fact, I had a patient a couple weeks ago who I don't know if she's listening. She actually she has a hot yoga studio. She does a lot of great stuff, and she started taking her husband's testosterone, which is 10 times greater than what we prescribe
Oh,
as. And she was feeling amazing, and she was pissed at me that I couldn't prescribe that same dose. But she definitely is on which there is a major risk of permanent side effects, um, balding, hoarse voice, something called clitoromegaly. But I think the topic of sexual health is such an important one. It is not
mm-hmm.
about it nearly enough way among OB/GYNs, my colleagues. Sexual health is such a huge issue, and people talk about the orgasm gap, the difference between how many orgasms men have versus women. And to me, as a male OB/GYN, it actually makes me sad of the way I hear certain conversations go on.
Mm,
Women should be able to enjoy relationships and sex, physical, for so much more equally than they and their partners than really what's happening out there. So um, uh,
yeah,
there's a lot of great information out there, some great podcasts. If anyone wants to, I can share some. So
sure. Yeah, go for it. This is the forum to do it. So if there's one or a couple you recommend, absolutely.
I don't know if my colleagues are on this call. There's a woman named Lauren Stryker. She's a professor of gynecology, sexual dysfunction at Northwestern University, my alma mater, and she's awesome. She's got this podcast called Come Again. And then
Clever.
Peter Attia, who people may
Oh, yes,
in the story of
yes.
longevity, he has a great podcast with someone that I recently listened to. And this um, um, Peter Attia has a podcast on November 3rd of 2025, and it's a
Okay,
really great podcast interviewing a woman, OB/GYN out in San Francisco, who definitely says it as it should be said for this topic. So I recommend
great.
listening to that podcast.
Thank you for those recommendations. Um, I think your point about the focus of sexual health really is one that has been left by the wayside for sure. At the event we had a couple weeks ago, we did have a portion of one of our panels on that specifically because it is such an important part of the conversation, and women shouldn't be ashamed or afraid to ask for help in order to improve that part of their lives. You know, that we should be allowed, like you said, we should be allowed to have the same type of experiences and not miss out just because we're in a point in our life where our bodies aren't producing what we need to have those experiences. So thank you for saying that.
Actually,
It's really
listening to the
important.
podcast earlier today, one of the doctors was talking about um, burning calories. Sleep is actually such an important part of people's lives now. It's really becoming this marker of health from brain
Hmm.
health and cardiac health. And having sexual intercourse, sexual encounters, both by yourself and or with partners.
Hmm.
Studies have shown you sleep better and less issues about that, and burning calories. It's a lot more fun than being on a treadmill.
I
So,
mean, win-win.
so there's a lot of great stuff out there. So one of my favorite classes in medical school was sex therapy. I was behind for a month. I shadowed a sex therapist, and I was behind a one-way mirror, listening to couples talk. And if my practice of OB/GYN wasn't doing well, I could see doing that someday. But anyway, it's a very important part of people's lives. And it's important to speak to their doctors about what you could do to avoid having pain with intercourse, helping with orgasm, et cetera, et cetera. That's a huge part of menopause and second half of one's life.
Yeah. And it is really the second half. Like it's not just one third. It really is like half our lives for sure.
Yeah.
And I mean, again, back to the some of the stories I've heard, just have a glass of wine. It'll loosen you up. It's like that is the worst medical advice anybody could ever give. It's
Yeah.
horrible, and it's such
So
gaslighting.
I'll tell you the joke. I'll tell you that really drives me is to make sure that the second half of life is just as good as the first. But when I was giving lectures 30 years ago, I would give a little talk and I would start saying there's three women who are out for breakfast or lunch, and they're talking about when life begins. And the youngest says life begins when the egg and sperm start dividing, and the middle one says life begins when the baby's born. The OB/GYN slaps the butt and the baby starts to cry. But the oldest one, the wisest, says no. Life begins when the dog dies and the kids move out of the house. And that has stayed with me because my goal as a menopause specialist is to make sure the second half of someone's life is as good, if not better, than the first half. And I think that's what this is all about. Life is too short, and so there's so many things that we can help with symptoms and longevity as OB/GYNs that are important to offer patients. So that's where I come from.
Well, you're saying all the right things because this is exactly what I wish we could all experience and hear when we go to our doctors asking for help. It's very refreshing. And I think this journey of my own education about perimenopause and menopause, as well as what we've been doing with Not Your Mother's Menopause, I'm hopeful because we've really encountered so many providers who are getting the training and getting educated, and I really hope that that continues. And that brings me to another question that came up in the chat, which is um, the changing of the educational materials or requirements in medical school. Do you have any, do you know anything or have any suggestions on how future doctors can be better prepared? Like, does it start with materials and the types of courses that they should be taking and are required? Like,
I'm laughing because I have two kids in medicine.
okay,
In fact, they may
okay,
be on this right now. I have a daughter who's amazing, who's a third year OB/GYN resident in Chicago.
amazing.
And so I do have these conversations. They do have lectures along the way
Hmm.
that are interspersed, but no formal training.
Hmm.
And so she knows what I've been up to, and I know there's some doctors on her. She's at in Loyola in Chicago, and I know there's doctors on staff there that have certifications. So I think that is becoming more part of our OB/GYN training. But when you're a young resident working on surgery and dealing with so much stuff, one of our weakness as OB/GYNs coming out is office management.
Hmm.
Dealing with hospitalizations, labor, OB stuff, and or GYN pathology surgery. So the weakness thing that I had coming out was working in an office setting and seeing patients, and so that's very common in young doctors coming out. So I think there's a move among the Menopause Society to try to bring more teaching in.
Great.
Um, and then I have my other child's son is a third year medical student. And in fact, he's doing his OB/GYN rotation as we
That's
speak.
amazing. Look at that.
Um,
Your children are
and
following in your footsteps. That's
yeah,
great.
and anyway, I know he's doing OB/GYN right now. I'm sure in the 6 weeks that he's doing OB/GYN, he's probably doing some test questions about menopause, but I'm sure there's not many lectures about this topic because there's so much
Hmm.
to cover in a 6 week period.
Hmm.
So, but
That makes sense to me for sure.
yeah.
But as far as, one thing that I thought is maybe it's not something that ends up, at least for now, being part of the curriculum or a requirement during your initial training. But certainly, I imagine there's continuing education that happens. So is it something that would be required in the near future? I don't know if you've heard of any rumblings like that, but it would be really nice to know that that is part of a, continuing education and a requirement to have that kind of training and education.
As general OB/GYNs, menopause questions are part of we get recertified once a year. We do about 180 questions, reading pertinent articles, but it's self-selecting. So if you really don't have an interest,
Mm.
you're going to choose some other articles. Uh,
Hmm.
but I think that's where as I said, the graph of people becoming a certified menopause specialist is exponential. It's growing rapidly. So the conference I went to this past year was significantly more than the year before, and the numbers are mind-boggling, not just OB/GYNs, but other specialists like internists and nurse practitioners, PAs, et cetera, et cetera. So I think the field is definitely booming, and the menopause society is having its moment. So it's increasing.
Which is very promising for sure. Do you have any recommendations for providers who want to get this additional training or certification? I would imagine it's pointing them to the Menopause Society,
Yeah, it's
but
not hard. It's a process. You spend time reviewing the different topics. And you just need to pass the test. And so you have to study a bit, and maybe even you have to do a certain amount of CMEs, uh, continuing medical education to fulfill your needs.
mhm.
So you have 30 every 2 or 3 years and take the test to show the interest. So it's just you have to show that interest to go above and beyond what we learn as general OB/GYNs.
And that's what brings me back directly to the first comment I made about you as a menopause certified provider is thank you for taking that extra time to get that education because it isn't required right now. And it is something that is self-selecting. And um, it's really promising to hear that the number of providers getting certified is increasing. But boy, it'd be great if it would be,
Um,
faster, sooner, more.
I had like 8 months off between my jobs, so I guess I could have done. I did a lot of other fun things during that time off, but this was something that I always wanted to do, so it afforded me that time. And I've gotten to meet some great people within the community, so it's been a great thing.
That's awesome.
And I thank you as people in the community. I read a little bit about the three of your bios. I think it's awesome that you guys are doing this for the Bergen County and the people are, the mothers and the women around here in this community. So my hat's off to you because it really does make a huge difference. So congratulations on.
Oh, thank you very much. Thank you. We really wanted to start this as something, as three women in the community, our community here, really just to help them get the information that we had started to find on our own, and
Sure.
the other to work with a lot of the women in the community as patients or clients. And so it was like this combination of all those different desires that really prompted us to move forward and create the first event, which was in 2025, and to see it through again for this year. And it was just, it's very fulfilling, very self-fulfilling, and maybe a little selfish, frankly, to feel as good as we did coming out of the
Yeah,
event a couple
you're
weeks
doing a
ago.
great service to help educate everyone, not just
Thank
yourself,
you.
but the community. So I'm sorry I was away last week, so I wasn't able to get there, but I look forward to getting there hopefully next year.
Oh, yes, yes. And I'm
And
sorry you
Valley,
weren't able to
obviously,
make it.
Valley also was really proud to be a sponsor and be involved. So you got a great partner behind you there. So that's great.
Yes, we were very thankful to have Valley on board, and I really think that having local healthcare systems as part of it is really important because we're trying so hard to bring it locally. It's great to have
Yeah,
experts that are more nationally known, but having the more local providers really is going to make the difference because then those women know who to go to. And if not them, at least reaching out to get a recommendation. But the local healthcare support really is important for the work we're doing, and it was very appreciated.
yeah. I know Valley sponsors several lectures over the year. I know my partners, Dr. Kim and Dr. Beloff, have been giving local lectures. I'm giving one in a couple months for Valley in Ridgewood. So we're definitely trying to get out there too to help communicate, educate.
That's awesome. I have another question that came up in the chat. Is there a particular age or symptoms that you would recommend beginning these conversations with your physician if you're starting to see specific things or I know that there's a time or a range when your potentially in perimenopause, but is there a recommendation you have on an age or?
I think perimenopause is even having a moment also now. And I think, it's like a glider that goes up, plateaus, and then comes down. And that coming down, that delta, the change is around 45 or so for an average patient. Some people go through it early. The average age of menopause is 51, and perimenopause typically is 2 to 7 years before that. So around 45, give or take,
Mhm,
and symptoms is a time to
mhm.
start talking to your OB/GYNs, your providers, about things you can do to decrease the risk of osteoporosis, heart disease. I can go on, vaginal issues. So I think that's a great time to start talking about what's in store for you.
That's great because sometimes it's not about the symptoms as much as it's about the prevention as you're in
Absolutely.
perimenopause. And I think for me, it caught me off guard. I was definitely having symptoms way before I even realized I was, but I keep hearing that the sooner in that time when you really are technically in perimenopause, even if you're not feeling hot flashes or joint pain or whatever it is, it still is important to start getting that supplementation because of osteoporosis prevention and cardiovascular health.
Yeah, we mentioned Peter Attia before. He talked about osteoporosis as being a pediatric disease, which is really a
Mm,
for those people on this that have kids, young children, that things you're doing now as young athletes, young girls who are athletic, very thin, aren't having their periods, they are that much more risk for bone loss. You peak your bones around 2025, and it plateaus. And so anything you can do to increase that prior, including low dose birth control pills, is only going to be a positive thing to have less risk downstream. So things that we do
mm.
ages is that much more important. And that's just an example of the continuity of care or the continuum of life that things need to be done with heart disease, et cetera, during pregnancy and beyond that are changing with our thought process, that it's not just acute little things here or there. It's looking at the whole picture for one's lifespan.
And you pointing that out, that it's really about setting your kids up,
Yeah.
your daughters in particular, to have strong bones, especially if it runs in your family, which it does in mine. And so I unfortunately am behind the curveball on that.
Right.
But
But there's a lot of great things out there to help prevent bone loss.
right, and it starts with your diet and how you exercise and
Weight bearing exercise is huge. Lift strong. There's a lot of stuff out there that people need to be trained on how to use weights to help build and prevent osteoporosis. So exercise is probably the most important thing, more than any other medicine that's out there. So if we can
right,
get people
right.
to educate themselves on what's the right exercise to do, pounding the pavement, jogging, tennis is great. A lot of different sports to help with that. So
Mm-hmm. Yes. Well, it makes me certainly focus more and think more about the kind of diet. I certainly focus on it, but hearing you say that and position it like that Dr. Peter Attia did is it's very eye-opening because your bone health is really important. And as we get older, you know, the broken hip story I keep hearing about, once you break your hip at a certain age, you die within, what is it,
yeah,
nine
very.
months to a year? Is
There's some crazy statistic. I think over 50% of women beyond 50 will have a bone fracture. Like it's some crazy number. And, my mother at 90 this past summer fell down 8 flights of stairs and didn't break a bone. And
Oh my gosh.
we went to the hospital. They said it was a miracle. Again, she hasn't thanked me for getting her on that Prolia for so long. But it was a miracle. I mean, if you imagine a very narrow stairs and she fell down, so the fact that she didn't break her, hip and then end up with a pneumonia and die, from that fracture is, incredible.
That
So,
is absolutely incredible.
so
Yes,
there's think it's a disease that's not talked about, but it's one of the top reasons why people die. So it's a really important topic to discuss with your doctors.
for sure. For sure. And also, I mean, I know this isn't an endocrinologist's conversation, but the DEXA scans, getting them earlier than the 65, which is what the insurance company recommends for a baseline. I mean,
Yeah,
it should
there's a
really be
movement
at
definitely
50.
to most people who have any kind of risk factors based on their BMI, thyroid, and other things. I'm definitely starting to order baseline DEXA earlier than that standard care of 65.
That's great.
I'm,
I ended up
I'm
requesting one. What's that?
Yeah, and most insurances will cover it if you do it at 55, at a younger age.
That's great. especially like you said, if you've got the history. Yeah. Well, listen, I really appreciate you coming on and sharing so much. And we are so thankful again for the care you provide and being a part of the Menopause Center and to Valley Health for developing the Menopause Center and bringing together providers who have that focus and that extra education and for sharing all of your expertise and information tonight.
No problem. Thank you for the invite. I appreciate the time.
Thank you, Dr. Garfinkel. Have a good
We may
evening.
need in the future.
Yes, yes, likewise. Yes.
Thanks so
Good
much.
night.